I'm always
Recording has started.
I'm always a little nervous when I introduce very important people, mainly because their CV is so long and distinguished. But I'm going to say a few words about Aruni Bhatnagar. He had his formal training in India and then Galveston, Texas. But since 1998, he's been ours, and he is a professor of multiple things. So he's a man of so many talents. How can you be a professor of cardiovascular medicine, pharmacox, physiology, biophysics, molecular biology, School of Public Health? But he can, and he's a phenomenal researcher, a phenomenal NIH reviewer, uh, 500 articles, maybe even more than that. And in 2018, he became the director of the Envirome Institute and then his own section chief. He's that big and has that much research and people that he mentors. So in 2019, he's his own division chief. When I ask him what he's most proud of, he immediately goes to the humble side, and that's what we love about him. He's most proud of taking care of all of the young faculty and students and mentoring people. So without further ado, I really want to give Aruni some time here talking about a big project that he's been working on. Aruni, it's your floor.
Thank you, Chris, for the kind introduction. It's been a pleasure being in the division and working with you for this last couple of years. And I was asked to present something about the ongoing study, which we call the Co-Immunity Project. So before I begin, I want to check anyway, everybody can hear me, right? You can hear me, Chris? Okay, so I assume everybody can hear. So I'm going to talk about the Co-Immunity Project, which is a project that we started out of bare need and necessity and the requirement of a time. And so we've been working on this, and I thought, where are we going to go with it and what we have learned so far in doing this project. So as you know, one of the strange quirks of a time was sometimes in January, we had this big pandemic that started. It started all in China. And within a few months, it spread all over the world. And it has been, I think, the single most critical health-related event, at least in our lifetimes, if not in the history of the human race. So now that it has been declared a global pandemic, we have to deal with all its consequences, its sad tragedies, and its clinical and social challenges, not to mention its economic impact. So we have all been grappling with this, and it's far from over, and then we are all in the middle of it. So in our worldview, we should be able to mount at least a response and do what we can to be able to manage and understand and minimize the impact of this devastating pandemic. So as you know, this is all related to a virus called SARS-CoV-2, which is a viral infection and infects basically the airway cells. And it starts with the cleaving of the S protein that's on the top of the virus. And that cleaving of the S protein that makes it bind to the ACE receptor. And this ACE receptor binding that internalizes the virus and causes it to divide. And then the virus uses the machinery of the cell to create new virion particles or new virus particles, and the infection progresses. And then this gradually increases and becomes progressively more elaborate, and it involves the actual immune response, and this immune response then creates sort of a production of cytokines in the lung, and the lung cells try to get rid of the virus and bring in sort of a lot of immune cells, and that probably gets more and more sort of complex and leads to a continued inflammatory response, and it results in sort of alveolar interstitial thickening, increases vascular permeability and edema, and therefore causes, sometimes pulmonary thrombosis, coagulation, and increased cell death, particularly the death of the immune cells. And so this leads to increase into the pulmonary permeability or local vascular leakage and the clinical complications. So in the initial picture of the disease that emerged from Wuhan, China, was that we could have most of the people infected were middle-aged people. They were some of them had severe disease, some did not have severe disease, some had complications, but a vast majority reported symptoms like cough, which is about sort of 67% people, although there are also a variety of different complications or symptoms. For example, fatigue was reported by a large number of people. And in cases of sort of severe disease, these symptoms were even more severe. So it soon emerged that there was a group of people that were much more susceptible to the virus than others. And if sort of progressive understanding brought us to realize that about 50% to 60% people who get infected remain pre-symptomatic, or maybe it is the pre-symptomatic people can transmit it. And a number of people can, once they get the infection, do not show significant symptoms. But the people who do show and who are hospitalized show fever, dry cough, fatigue, then myalgias, and also say nausea and vomiting. But there are also sort of common lab findings. For example, lymphopenia is very common in the state. There are also elevated levels of different inflammatory biomarkers and also increased coagulation. In fact, some people think that coagulation is so important that it may be one of the reasons for the severe cases where you have disseminated coagulation around microvessels, and it's very difficult to then perfuse end organs and leads to multi-organ failure and death. So what we need to understand is what are these particular complications and why these may be. So if you look at the common radiographic findings, you will see that there is sort of in the lung, there's a lower lobe infiltration, and you get this ground glass opacities, and these get consolidated and therefore may be preventing air exchange in the lung. There is common reports of pneumonia, acute respiratory stress syndrome, but also other things, for example, cardiac injury, acute heart failure, arrhythmias, and myocarditis. In some cases, there is this extreme cytokine storm because it sort of simulates sepsis. And so there is rapid and premature death. So this is all by now household knowledge. Everybody understands that this is not just a simple respiratory virus. It causes multiple complications, and we have been dealing with it for several months. So although we don't have a targeted treatment, some sort of secondary treatments are useful. But the most important thing that we can do is to identify the disease. And so the infection needs to be diagnosed as promptly as widespread and in such a widespread manner so to be able to start the treatment. One. Second is to isolate infected individuals. Then we have to estimate how many people are infected and what's the rate between the people who get infected and people who are dying, so that we can estimate what sort of mortality there may be. We have to do widespread testing to figure out how the infection is spreading in the community, how to identify different hotspots, to understand the extent and the response, immune response that people mount against the infection. And even when the infection rates are going up and down, we need to continue to monitor, because you want to sort of know or survey what is happening in different parts of the community, where the infection is high and where the infection is low. We have to track these trajectories and develop public policy accordingly. I'm sure we have heard a lot of debate about when to open schools and businesses and functioning offices. And then we need to know the specific rates of infection to plan for healthcare needs, and that's particularly critical. So these efforts have been ongoing for a long time with varying degrees of success. But one of the things that emerged early on both with the disease and with the testing, was that it uncovered generations of disparity within our society. And we've known for some time that there are certain sections of the society that are particularly vulnerable to infection, and even when they get infected, they are particularly susceptible to long-term complications and adverse outcomes. And we've seen this in the health disparities literature, and you can see that certain ethnicities are much more likely to be susceptible to different types of clinical outcomes. For example, the Latinos have a much higher rates of diabetes. The African Americans have much higher rates of heart disease and hypertension and stroke. And then the Asian Americans and Pacific Islanders have much more liver cancer. So there is a host of different diseases, and I think with the exception of suicide and some sorts of cancer, most diseases are much higher, have higher incidence in Black communities than it is in the general communities or in the majority population in the United States. But so we have to realize that these sort of disparities.
Medication. You should.
So these disparities do matter, and that in the end we have to be attentive to it, because I think Black health does matter and it does make a difference. So we have to, and we know that the same thing is recurring again. And what is happening is that the rates of infection plus the actual morbidity and mortality associated with the disease is so much higher in African Americans, both the females and the males. So
Hold on, Dr. Bhatnagar. We're getting.
I'm just stopping for a moment, Jason. Somebody's not talking. All right, I'll continue. Hopefully, whoever is talking will be muted.
Yeah, that was to check your liver.
Hold on one second, Dr. Bhatnagar.
Okay.
Dr. Condon, can you please mute your mic?
Sally Condon, please mute your mic. I'll text her.
Okay, thanks.
Okay.
Okay. So we know that the population, especially the African American population.
Did you ever use IV drugs in the past?
Hold on just 1 minute.
I guess I speak louder was difficult. All right. So I think that the data that we have to date shows there's much higher incidence of the confirmed cases in Blacks than the other races. And we see a similar sort of propensity or similar vulnerability in case of coronavirus deaths. You can see this is data from New York showing that the mortality is so much more higher in Hispanics and Blacks than it's in white, although in a different mix, for example, in New York State, there is much higher mortality in whites. So it depends not only who you are, but also where you are. That would determine the susceptibility to infection as well as susceptibility to the outcomes. And then we compare data from different states. This is data from Louisiana, Michigan, Illinois, and North Carolina. And you can see that in places there is much higher vulnerability in minority communities than in other places. So it means that the burden of the disease is not evenly distributed within our society, number one. Number two, that it is not a simple matter of a sort of race. It also matters, in addition to race, place matters as well. And this is shown here from data from Chicago, showing that there are certain areas that are much higher in infections than others. And the reason is also not only that there are intrinsic biological susceptibilities that predispose some individuals to the disease or to the infection and to the severity of the infection, but also there are environmental vulnerabilities which means that if you're living in a closed environment and there are 5 people sharing the same apartment, and you're living in a cities where there are much higher population densities, then you might have a much higher risk of transmission of the disease and much poorer outcomes. So in order to really grasp what is happening with the infection and the severity of the disease, we need to pay attention not only to intrinsic biological vulnerabilities, clinical susceptibilities, pre-existing conditions, but also environmental factors and societal sort of structures that allow the disease to progress and facilitates its adverse outcomes. So to sort of start to understand all of that, we thought that we need to really to get a grasp of this, of the infections and disease in our community. And so we launched what we call the Co-Immunity Project. So the Co-Immunity Project was officially launched, I think it was in April, which was an early response. It was launched formally by our president of the university as well as the governor of Kentucky in an attempt to understand the extent of infection and the spread of the disease in Louisville, or at least in Jefferson County. So this was a joint collaboration, an idea that developed from the Louisville Healthcare CEO Council. We had all the major hospitals and in the area, we got together and thought that we have to have a unified response. The initial sort of expectation at that time was maybe we should share experiences, the type of things that we are doing, data, we share experiences with the PPE, and so we would be able to see which type of kits were working and not working, and we went through a lot of debate about that, and then how these kits should be distributed and how the data should be disseminated. So we started this whole project together as a collaboration between the area hospitals as well as the entities within the university, the Christina Lee Brown Envirome Institute, as well as the Center for Predictive Medicine. So initially, though, it was conceived that we would be able to identify those who were infected and get them to donate plasma to the blood bank, and from there we might be able to use that for plasma replacement therapy and convalescent plasma replacement therapies for people who need them, but also that we would be able to long-term monitor the infection and the outcomes of the disease in our community. So it soon developed into many different phases, and we thought that we would the project would be able to evolve accordingly to need and be able to address not only societal and clinical needs, but also in our understanding in terms of public health, but also sort of civic policy of what is it happening with the community and how do we deal with that. So the phase one was of the project was to look at healthcare workers, because we thought that the healthcare workers are more susceptible and vulnerable, and certainly the most important and precious sort of sector of a society, especially in terms of an ongoing pandemic. And so we need to be vigilant and be able to identify rates of infection there. Then we thought we'd follow and do a randomized sampling of the community, and I'll tell you some of the rationale for doing that, given all the disparities and importance of the demographics of an individual, but also time and place. Then we thought that we need to follow up in detail what happens to people in the different communities and what happens to them, and then we could go and extend that to rural communities if necessary, and then we have to have a long-term clinic for people who have actually survived COVID. So I'll start with the first part, which is the sort of healthcare worker studies of the co-immunity one. And we've known from literature that people have looked at the spread of infection in healthcare workers. It might be of great interest to people here who themselves are healthcare workers. And they found that there is a sort of a reasonable level of positivity, and that there was not much difference between the frontline healthcare workers or what they call the frontline healthcare workers, and they seem to have a really steady rate of infection, which sort of was around 5%. So, which means that there was some level of residual risk that will exist in healthcare workers, irrespective of the changes in the rates of infection within the community, which I don't think is entirely true, and that we would need to revisit this idea that that regardless of what's going on in the community, that the healthcare workers have a constant low level risk or a high level risk. We are not sure. So then the other study, which two different studies, one came from Wuhan, China, and the other from Essen, Germany. And what they suggested was that there was a very high level of infection, at least in Wuhan, and there were about 1% of the healthcare workers died, which is a very high number, although they thought that was much lower than SARS, which was years ago and killed as many as 21% of the healthcare workers. So that was startling, and most of it was attributed to working in an environment where you're exposed with patients and didn't know initially how infectious this particular virus was, and some thought that they were not really dressed up properly. They were reusing PPEs and so on. So therefore, that could have led to a very high incidence both of infection and mortality. Whereas in the data from Germany showed that there was a low level of infectivity, and this was using not PCR, but looking at seropositivity, and the seroprevalence in that in the healthcare workers were actually quite low. And so maybe by the time the study was done, that there was a much better understanding of how to manage the exposure clinically. Then a very large study was published, and they were looking at about 2 million people and about 99,000, 100,000 healthcare workers, both in the United States and in the UK. And they again found that there was the incidence of the disease, or the prevalence of the disease varies with the location. Some places have very high cases, some places not so much. We point out that Kentucky is in the middle. But the interesting part was that they found a very high rate of transmission in the healthcare workers than in the general community, which was very surprising. They found an 11-fold greater prevalence of the infection within healthcare workers than was present in the general population. And that was surprising because such a high prevalence has not been reported before, and it was not sure whether that related to the early experience of the people who were there rather than to the actual state of affairs now or in the last few months. So anyway, so we thought that we really do need to understand what's going on in our community and to what extent is our healthcare workers community at risk of being infected and being exposed to COVID. And so we launched the Community One, in which in the first round, I think that was done in April, we tested 1,372 healthcare workers, all from the UofL hospital. In special thanks to everyone, many of them may be here, who participated in the study. We found low levels of positivity with the PCR and a sort of intermediate level of the antibody positive. I think that rates of infection in the healthcare workers in our estimates are much, much lower than the rates of infection in the community. Although both data are highly suspect because we didn't measure every healthcare worker, and the data in the community, as you know, it doesn't have much value in the sense of actually getting to the true estimates, because the extent of infection depends upon who you test, how many people you test, and how they come to be tested. So all of that data is only very roughly indicative of the disease incidence in a community. Regardless, we found that there were low rates of infection. We repeated the study again in July, and we found again low rates of infection and low rates of antibody positivity, which was an intermediate. And we are going to keep doing this every 2 months to make sure that we have a firm grip on the type of infection spread within our hospitals. We know that there are other modes of testing. There are other ways the healthcare workers get tested. But I think this provides a longitudinal evaluation of not only the rates of infection within the healthcare workers, but also how the immune response develops over time. And from what the preliminary data we have, we think that there is that the immune the antibody titers and in the seropositivity status. Regardless, so we'll keep doing this. In our initial attempt, we found that most of the people who got infected were either nurses or physician assistants, and respiratory therapists were the most susceptible, not surprisingly. And most of them were either in the emergency department, the ICU, or in the hospital floors of UofL hospital. So we are trying to get a better understanding of the spread of infection and understand where are the most susceptible places within the hospital, which particular professions are most likely to be exposed. Incidentally, we found very few physicians who were infected from the coronavirus. So, as I said, this is ongoing work, but then we also wanted to know what was the parallel rates of infection in the community. And if we know the rates of infection in the community clearly, then we can go back and understand what's happening with the healthcare workers. So we need to have an understanding of the true rates of infection in a community. So how do we do that? How do we get a true infection rates in a community? So suppose we look at our community, the Jefferson County. We know that Jefferson County is a very sort of diverse county. There are areas that are segregated for one reason or another, which is a very unfortunate set of circumstances. But there are areas that are predominantly white, which have 86% white population or 91% white population. And there are other areas in which white population is about 28% or 45%. So there are discrete areas in the city which are demarcated in terms of their socio-demographic distribution. And so if we just go and sample people from one place or the other, it may not be reflective of the other place. And so in order for us to be able to understand the spread of infection within the Jefferson County, we have to ensure that we have equal proportion of sampling from each of the demographically distinct zones or areas within the city. So now that we identify these 4 different zones and within it like 8 subzones, that we could then stratify our randomization approach so that we are inclusive. So for that, we have to get to each area, and these are the 4 areas that we identified within the county. We have to ensure that we have a fixed number of populations from each of these areas, so that we have equal number of people from each of these areas. We want to make sure that there is a proportional sort of representation of race from each area. So if we get to area 1, we have to have some number of non-whites, say at least like 200 non-whites, but 200 non-whites and about 80 whites, like that. So we have to have a specific distribution of people depending upon the distribution of the population of whites and non-whites and Hispanics and blacks within each community. So this gets rather complicated, and then we have to weigh them appropriately, and we have to ensure that the people we want to test are the people who would come for our testing. So, and then we have to ensure that we have a equitable race, age distribution. We don't just want to test all old people or only young people. So there would be an equitable age distribution, and of course a 50-50 split on the sex. So these are very complicated algorithms to actually work out an appropriate sampling scheme that would be representative of different areas, of different sort of race within that area, which is representative of the ethnic mix in that particular area, as well as age and sex. So once we started that, we thought we would be able to write letters to people, and people would come forth, and we would do the study, and it would be sort of relatively straightforward to get important and reportable results. But things didn't turn out to be that simple. We invited over 18,000 people from the community, from different parts of the county. We only got 500 responses. And we do not know whether the response rate was so poor. Maybe we didn't give them enough time to respond. Maybe lots of things were going on within the community. At the time that we were doing the tests, there was a lot of disquiet and protests. But we do not know whether that contributed or not. But regardless, we got a very poor response from the people that invited. We did get a lot of people who wanted to get tested. So there we call that a volunteer sample. So overall, we tested about 2,000 people. But we did get a very sort of even or homogeneous distribution of our participants from all different parts of the county, so that we can at least get some sort of an indication of the sort of area level spread of infection within Jefferson County. And so that allowed us to be able to make some estimates of where the rates of the infection would be higher. Overall, we found that the viral infection rates were very low at that time. It was in June when we had a dip and before the July 4th break. But there was a very sizable amount of population that was positive to the antibodies. So showing that the virus has really permeated into Louisville. And in June, we had reported 4,000 cases total in our county, whereas we think that as many as 20,000 people may have been infected. So it suggests that we had been grossly underestimating the rates of infection because we have relied primarily on convenience sampling and not done a sort of a random evaluation of the community. So now to sort of get this aggregated into a set of risk assessments into different places, what we see is that part of the county, the total, what we think true fatality rate is about 1%. But however, more than 1%, but the fatality rate for whites in our population was 1%, but the fatality rate for non-whites was about 2%, double the incidence for white people who were infected. So not only, again, it sort of tells us the same things that we have learned from national data. The place matters. There are people who live in certain areas who are much more vulnerable an individual susceptible to the infection, and once they're infected, they are much more susceptible for mortality and adverse outcomes. So this would say that we have numbers that would support this overall general calculations, but because these numbers were actually derived from a very small number of people, about 500, 600, of whom were actually from the random sample, but most from the convenience sample. So most of the data may be a little bit off. Moreover, although we weighed the convenience sample different from the random sample, there are still sort of methodological concerns. So in order to get better data and in order to get more concurrent measurements of rates of infections, we repeated this again, and it's called the Wave 2 of the Community 2 project. And in the Wave 2, again, this time we sent out 30,000 letters, and we sent them letters maybe 2 weeks before the testing. Maybe I did or not, but we mentioned we do our testing here at the different sites within the city with the participation of ULH, with Jason Smith and Hugh Schaff and their team. There we set up 4 or 5 different testing locations around town, and within a 2-week period, we test about 2,000 participants. So this time we got a very good mix of people. The volunteer set was lower. We did did do testing on some people who just showed up because we thought it would be sort of rude to tell people not to come when we invited everybody to come. But we wanted and focused on the people from our random sample. So we got a good distribution of the random sample set. We tested 2,000 people. We tried all we can. We actually went door to door asking people to come and to participate in the study. We even launched a hot air balloon, and this is shown where we were trying to test it within the university for 3 days. We launched the balloon in the community so that people would know the name of the project and would trust the project and the project investigators. We had Dr. Bendapudi sign the letter of invitation to invite people to the study, and we had did a variety of different public service announcements to spread the word. And after all said and done, and we did the actual evaluation, this is what we found. So this is a little bit complicated, so let me go through this carefully. In our random sampling set, we tested 1,500 people. We found that 4% people were positive in terms of their antibodies. So our confidence intervals range from 2.8 to 6.9. At the time, it would mean that 34,000 people in Jefferson County were infected with the virus. Now, this could vary from 20,000 to 50,000. To date, we have officially reported 17,000 cases in the county. So again, we are much off from where we need to be in terms of the rates of infection and the prevalence of infection and or cumulative exposure to the virus during the course of the pandemic. So that was one lesson. The other lesson was, if you look at active infection, we found that 0.2% of our participants were infected, which means that there may be 1,500 people in Jefferson County that day or that particular, averagely on that week, which could vary from 400 to 4,000. That's a very high confidence interval range. But the reported infections were only 700 average for that week. So it means that we are missing a lot of infections, we are only catching half the infections, and that's reflected in the antibody data as well. So we could say with some degree of confidence, because we have sort of developed a very sort of elaborate system of weighting, and we've tried all we can to get a proportional representation for different parts of the city, that we are underestimating the rates of infection by half. And that, more importantly, that there are areas in the city which are much more likely to be to have higher rates of infection and severe outcomes than other areas. And certainly it's not a surprise, but it does tell you how starkly different the rates are. They can vary from 1.1 to 2% to 4 to 10%, even within the county, and that our civic authorities, as well as community activists, plus our medical establishment, needs to be cognizant of these disparities and then try and develop attempts to minimize such inequities as they exist. We found a similar picture in our convenience sampling. Again, the numbers are low, so we won't trust them very much. The interesting part here is that of these people, in the sort of convenience sampling, more people are positive for the virus and less people are positive for the antibody. So it seems that people who have had virus a long time ago wouldn't on their own show up for testing, but if they feel that they might be infected, they do tend to show up on their own without any invitation. So these differences in the data highlight the different sort of rates of success of the randomized sampling and convenience sampling in getting the true estimates of the incidence and the prevalence of the infection. So anyway, we will do this again. We are planning to do the repeat this co-immunity 2 again. I think in early November, if there is, I don't know if it's still we have a functional city after the election, and whether we will be able to be out and about testing people and talking about infections and COVID rather than other things. So And then I think we will do another one in December. But at the same time, part of the co-immunity too is to be able to look at the rates of infection in a different way. And one way of looking at it is to look at the wastewater. Other cities have done it, and it is sort of useful because it moves us beyond individual testing so that we can identify a whole population with less resources, and then we can repeat it on almost on a daily basis if necessary without going to the expense of trying to test the entire population at a time. And how it works is that you actually collect community wastewaters at the wastewater systems. We collect samples, and these samples sample the wastewater every 15 minutes for 24 hours. So we get an aggregate sample, and then we analyze the sample, just do a PCR so that we're able to know whether there is virus in that. And this has been sort of used for a while. It was used for HIV, for polio, to figure out what parts of a particular urban settlement would have more or less virus, or whether or not some parts have different drug usages than others. People have been using this to monitor opioid crises and so on. And it's been shown to be successful in the case of SARS-CoV-2. This is data from New Haven, Connecticut, showing that the rates of increase in the virus in the community wastewater precede the clinical cases or admissions. And that is because individuals shed the virus in the fecal matter about a week or 5 to 8 days before the actual clinically developed symptoms. So it may be useful. It is not an exact science, but it is another modality that gives us some grip over what might be happening in the community. And so we have to try and attempt to see if it could be of use here. The one difference that we have in a city is that our sewage system is quite old, from the 1800s, and so it's difficult to get a very even distribution of the population. But be that it may so, we are trying to monitor 8 different zones of the city, and we are then monitoring the wastewater every 2 weeks at 15 different sites, and then be able to get the data in the lab and get the results out so that we would be able to provide the city the information if there are hotspots and areas within the city, and whether the rates of infection are increasing or decreasing in real time. The actual problem with this is there is no standard methodology. We're still trying to struggle. We are on a number of national groups and work groups together with the CDC and the EPA to try to harmonize these efforts nationally, and then be able to get a clear and it's a reasonable and meaningful picture of where the infections may be. We can do this with high resolution. We don't need any like IRB and all these elaborate setups. And so we could be able to provide this sort of service to the city and to the general community by being able to find out what the rates of infections may be in different types of places. And we've been doing this for the last month, and our sort of initial data show the same thing as our, or more or less the same thing as our serology measurements and active infection measurements, that there are certain parts of town that have much higher rates of infection than other parts of town. And then we could localize this to certain areas and neighborhoods and so on. And this is a very important and useful information for the city to deploy its resources of where we need to pay more attention. Plus, monitoring different places and time gives us sort of an understanding, albeit a rough understanding, of whether the rates of infections are increasing or decreasing in the community. So we are going to continue to do that and provide a continuous data information to the city and to our community, if necessary, of where the rates of where infection is and what the rates are, whether we're seeing an increase and decrease, independent of the types of convenience sampling that the city and the state are doing anyway. So I think this is one important part of the project. The other one, then we need to keep working in understanding what are the long-term consequences could be. So we have to look at the environmental changes, how they might be contributing to the spread of the disease. We are going to then go into phase 3 of a project, which is to look at the people who were tested positive with the antibody. We want to bring them back and then test whether their immune responses are preserved, but also be able to do a detailed clinical and biological and environmental evaluation to be able to understand why they got the disease in the first place, how they responded to the disease, and what is happening to them after they recovered from them. So we want to make sure that we know what is happening to immune responses in the long term, what happens to the cardiovascular and the metabolic health of these people, and what sort of socio-economic changes that happen to their lives as a consequence of this of getting an infection, and how they got the infection. Were there certain demographic features that distinguishes the people who got infected from the people who did not? I think this will be important to understand what happened. More importantly, it also important is to figure out what may happen in the future with this pandemic and other pandemics that are likely to recur. But an important obligation, I think, to our community is to create a clinic that we would be able to see these people, these individuals who recovered from COVID, and to be able to monitor their health as it might be affected long term because of this bout of infection that they had for a few weeks and survived. So we know from data, again, there's cumulative work showing that there are many extrapulmonary manifestations of COVID. We think there are neurological symptoms that occur. There's sort of renal complications, hepatic, GI. Of course, thrombosis is a major event and may be responsible for a vast majority of the mortality associated with COVID. There are also very marked cardiac sort of changes, arrhythmias, ischemia, and myocarditis. There are endocrine as well as dermatological changes. What they don't mention here is also cognitive changes associated with COVID. And so a partial list would suggest that a vast majority of people who recover from COVID have fatigue and dyspnea, and they have cardiac dysfunction. A very sizable proportion of people have myocardial inflammation, and we do not know how long this takes to resolve or whether it lingers for a long time. We see that there's some form of neurological symptoms, and even very young individuals who had not had any sort of dramatic symptoms report having problems breathing and show signs of subclinical pulmonary injury months after the infection. So this is not a sort of a simple infection that whoever survives has survived and then it'll sort of extinguish from our community once the vaccine appears. But it seems like we are going to be left with a group of people who have long-term health concerns, and therefore it behooves us to be able to be vigilant to this possibility. And if we do not attend to the long-term complication of the disease, we might be missing a significant health concern of our community. There are many questions that we can ask, and this is just a very small fraction of them. The questions such as, what happens long-term to the lungs? What happens to the heart, and how does that change long-term? What are the type of changes we see with COVID survivors different from what we will see in a normal uninfected population? Whenever the people who survive from COVID have an MI, would it be the same MI, or would it be much more severe? We do not know whether this long-term COVID can trigger arrhythmias, and whether the arrhythmias triggered by COVID may permanently alter ion channel function and structure such that we will see many years down the line an increasing incidence of arrhythmias. Similarly, we have to worry about renal injuries and insulin regulation. We have to worry about neurological complications and persistent cognitive changes. So there is a lot of cause for concern that must and should be followed up if you're serious about being responsive to the needs of a community. And so we think that it would be important to manage this sort of long-term complications by initiating a clinic that would actually first create a statewide registry of the people who survived COVID. We also need to understand what these complications may be and follow them comprehensively over time. We've tried to create a dialogue between the Envirome Institute, but as well as CPM, Traeger Institute, and UofL Health. And I hope that these talks will be productive. We look from the university leadership to guide us into this new direction and create something of substance and meaning that would be of great value to our community. So we think that we are here to be able to work with the community and be able to learn about the disease, its infection. I was giving a talk yesterday and somebody asked in the audience that, how long do you think the co-immunity project will run? And so, surprisingly, I found myself replying that we would be here as long as the infection is. So we cannot do this and in between sort of pack up our bags and go home. So if we have put our stake in the ground, we will continue fighting this infection as best as we can, both by looking at the rates of spread in the community and in healthcare workers, but also providing new understanding of what's happening locally. We need to collect the virus, local virus, and sequence here to figure out what sort of the shade of virus that we have, or are there any concurrent mutations. We cannot just be sitting here and waiting for information and guidance to come from the East Coast or the West Coast. We need to develop our own understanding and learning and tell the world our experience of what has happened to us during the course of this pandemic. So I'm going to stop here and acknowledge a whole range of people who've been very critical in getting this work off ground and participating in this. It is a very grueling task to be out there 10 hours in the field, taking samples and then be able to collect them and then run them to the lab and get the data back to the people within 6 to 12 hours in most cases, and then be able to coordinate all of that and sit there and write papers. So I'm really very proud of our junior faculty, particularly Rachel Keith and Barbara Cave, who have sort of devoted a vast majority of the time trying to get this to function. But most importantly, I also want to thank our people who've been supporting us, a range of people who've been very, very helpful. We were out there asking for help when we had no resources and we urgently needed to start the project. And we were very fortunate to have responsive members in the community, both the Jewish Heritage Fund for Excellence and James Graham Brown Foundation, as well as the Osley Brown Foundation, that came forward and supported this research so that we would be able to continue this work, or at least start this work and continue it for some reasonable amount of time. So I'm going to end here and see if there are any questions or comments that you might have.
Yes, I have a question this morning. This is Dr. Emmons of Heme BMT. We have a rare opportunity, it seems to me, given the situation with a minority population and a strong microbiome group here on campus at U of L. There are major questions with regard to the distribution of the severity of the disease, given that the minority representation is so variable, but fits somewhat with the variation in microbiome classes between minorities around the country. So I wonder whether the microbiome issues, which we know contribute to metabolomics and immune system differences between individuals, are part and parcel of what lead to the difference in intensity of immune response as well as mortality between individuals. So have you reached out to any of our microbiome groups here to ask if they're interested in studying these variations, which might make a very big difference to the understanding of this disease as a whole?
No, so not. And I think that's a oversight on my part, and we should reach out to them. You're right. There are likely to be great differences in microbiome that might contribute to the disparities in infections and adverse outcomes. I do not know of any national data that have actually looked at the issue. It is a difficult problem to grasp at because we want to look at microbiome at the time of the infection, post-infection, or pre-infection, which is almost difficult to do. So we need to be careful about how we design the study, but certainly thank you for bringing it up. I would contact people who have expertise in this area and we'll try to work with them. Any other questions or comments?
So So, as Aruni mentioned, a group of individuals are getting together for the post-COVID clinic, and Christian, you're on the line, and I don't know if Bridget Hittapol's on the line, I don't know if Ruth Carrico's on the line, but we recognize that we need help. I mean, Robert just asked a very good question. You know, what about the microbiome? I'm always saying, what about vitamin D? You know, black and brown skinned people have lower levels of vitamin D, and there's influences in vitamin D in your immune system. What about the ACE receptor all over the body? There's so much about the pathophysiology of this. I completely agree that we have this tremendous opportunity to collect data and study longitudinally long-term healthcare effects. When we design our clinic, though, which we're doing right now pretty rapidly, we have to be forward-thinking and need help from various groups of people like you all in order for us to construct the appropriate questionnaires. You know, should we do, what kind of breathing test should we do, you know, to assess for dyspnea? Should we be doing neuropsychological testing? We haven't talked about psychiatry with COVID and how that might be managed as well. So there's all these pods coming together that we're trying to create a multidisciplinary clinic with Aruni's help. And you see, he's excellent at getting everybody together, and that's what he does. And then it's up to us to make it happen. So we need a lot of help, and anybody who's interested should directly contact Aruni, myself, Christian Furman, and, you know, let's go ahead and create a really robust phase 5 with the chronic care clinic.
So,
There's
all right.
there is just real quick. There is one question in the chat area for you, Dr. Bhatnagar.
Okay, I can't read it. Can you read it for me?
Yes, it says, are you testing for vitamin 25 that's OH-D3 levels?
Vitamin D levels. That's Chris's favorite topic. No, we are not. That's why we want these people to come back. We do know. I mean, how do I go measuring it? Because I can measure it now, and I don't know who's going to get infected in the future. So there isn't a way of directly measuring. What we could do is we know that the levels of vitamin D are much lower than in the black population and the Hispanic population and the whites. Whether that's responsible is a different matter. So we would have to maybe rely on a clinical test. And I've seen like 4 studies from Malaysia, from Singapore, from Italy, from Japan, which have shown that if you intervene with vitamin D early, that you might be able to help a little bit. But more importantly, that people with low vitamin D levels have worse outcomes. So that's kind of what people know, but the intervention is very spotty data, and we don't know whether that's really true or not. But we do know that there's a susceptibility. But when we bring people back for the study, and we would follow the vitamin D levels, but I think that would be after the fact. So it's a very difficult question to get into unless somebody does a randomized clinical trial as a vitamin D as a prophylactic use.
So we are going to check it when they come to the chronic COVID clinic, and we are going to supplement them, and you know, maybe those that get levels that are improved. As Aruni said, if you've already got the infection, you've already got all of the negative, you know, problems. Is that track going to look different if you have better nutrition, better air, better water? You know, there's probably a variety of cofactors to immunity. So one of the biggest things is going to be, as we understand the pathophysiology of the disease and the immunity, and then what can we modulate to Aruni's point? What can we modulate, and how can we get it there first so that they don't get the infection at all? Why is such disparity and divergence in susceptibilities? Is it genetic? Is it environmental? Is it nutritional? So,
right. If there are no more questions, then thank you very much, Chris, for the invitation to present this, and thank you everyone for your attention. If you want to be a part of this sort of project with the community, please let Chris and me know, and that we would welcome input both in our ongoing community testing part and healthcare workers part, but also in our in the clinic. And certainly, if we come to you requesting participation for testing, please help us by being a participant in our studies. Thank you very much. We'll see you soon. Bye.
Thank you, Dr. Bhatnagar. And thanks, everyone, for joining us this morning. And we'll be back next week, same time, same channel. We'll be have a talk from Dr. Michael Breyer from the